I'm Pat Garrity, an instructor of medical laboratory technology at a two-year community college.
And I'm not. I'm Jerry Walters, a supervisor of a clinical laboratory in an acute care medical center. In this video, we will include the why, when, and how of performing smear reviews in hematology.
The why of performing smear reviews is very important. In the past, whenever we were to look at a smear, we were programmed to perform what we called a diff, which included three things: differentiating 100 white blood cells, observing red blood cell morphology, and looking at the platelets. In today's laboratory, a lot of the routine screening is performed on hematology instrumentation, so that when we need to look at a blood smear microscopically, we need to approach the task differently. The smear review is a cost-effective alternative to the old-time manual differential and makes the hematology lab run more efficiently. Smear reviews, when done properly, can confirm and enhance the information already obtained.
When would you perform a smear review? Smear review should be performed first and foremost when your instrument tells you to. Many current hematology analyzers generate a variety of flags that alert you to the possibility of a morphologic abnormality. These flags are often called suspect flags. They include blasts, left shift, bands, immature grands, or a combination thereof, atypical, reactive, or abnormal lymphocytes, nrbcs, platelet clumps, platelet interference, and/or microcytic RBCs or RBC fragments. Another way your instrument may tell you to review a smear is by displaying unexpected histogram or scattergram interference. All of these things do not necessarily mean you have to perform an old-time differential. It just means you need to look to see if they are there or not.
Some numbers generated on instrumentation also should be verified by smear review. These include low platelet counts, defined by your laboratory, and abnormal absolute numbers of white blood cell types. Criteria should be set using absolute numbers, as this is more reflective of patient status than percentage values. An example of this might be requiring a smear review whenever the absolute eosinophil count is above 800. There are some numbers generated on instrumentation that a smear review will not help confirm. These include hemoglobin, hematocrit, red cell count, and red blood cell indices. The hematology instrumentation of today is certainly better at evaluating these parameters than our eyes are.
Now that we have told you when and why you would do a smear review, we're going to tell you how you do a good smear review. There's both an art and science to performing a good smear review. It is no less clinically useful than the old-time manual differential and requires the same expertise. The science part of the review requires a properly stained, well-made smear. Another part of the science is verifying numerical results. These include platelet counts, WBC counts, and automated differential counts. To verify platelet counts and white cell counts, you need to establish calibration factors for your microscopes. In your documentation manual, we have included a method for doing this. In our experience, it works well for platelet counts. WBC estimates are another story. The story is, it works poorly at best. Why they work poorly is because of the low numbers we are dealing with compared to platelets and distributional problems. When you attempt to do an estimate under low power, the area is too variable. And when you try to standardize the area under a higher magnification, your view is too limited. Trust me, we've tried everything.
This is really too bad because there are times when verification is needed. nRBCs are a perfect example. Various automated hematology instruments handle nRBCs differently. On some instruments, they are part of the white blood cell count. Others exclude nRBCs from the counts. And there are those when some are in the count and some are out of the count. Also, sometimes it depends on the type of nRBCs. When nRBCs are the size of white blood cells, as seen here, they will probably be included in the white cell count. When you have this many, is when some will be included and others excluded from the count. What to do? First, you need to know how to recognize WBC interfering problems on your instrument. On instruments generating histograms, you will often see what is referred to as a high takeoff. On instruments generating scattergrams, there are specific areas where interfering particles will show up. In some cases, you have to rely on instrument flagging if no picture is available. Sometimes an estimate will help. You should be able to tell if the white blood cell count is high, low, or normal. Many times you need to have an alternate method because of the weakness of the white blood cell estimate. Alternate methods include the very scary white blood cell count manually performed on a hemocytometer. If you have to do this, at least use a Unipet device. A more efficient and accurate way is to use a small instrument which has the capability of counting all nucleated cells. This eliminates the question of where the NRBCs are, in, out, or some in and some out. These small instruments, when adjusted properly, count all white blood cells and all NRBCs. This number can then easily be corrected.
I think NRBCs are a pain in the aperture. You thought I was going to say something bad, didn't you? The art of how to do a smear review begins with taking a different view of the peripheral blood smear. Pat calls it window shopping at a distance. From a distance, you get a much better overall view. As you get closer or increase the magnification, your view obviously changes and becomes more limited. As you can see under low power, you get a very broad view of the distribution and clue as to what you will see under a higher power, as seen here. Sometimes when you get really close, you limit your vision so much that what you see is not necessarily what's important or representative. If your only view of a smear is this close, you could miss this, a blast. So you start a smear review from a distance, getting a general impression of the smear. On low power, you should make a minimum of 2 trips across the entire width of the smear. Then you go to a higher power, 40 or 50x. You should examine at least 20 to 30 fields. While you're traveling in these 20 to 30 fields, you may need to go to a higher magnification to identify or confirm something, but most smear reviews will not require this step.
In your documentation manual are 2 charts that you can refer to as we present how to perform a quality smear review. The first chart is used to guide you through the basic process of performing a smear review, what you are looking for when. The second chart is actually the process, documentation, and suggestions for reporting a smear review. The smear review is a test that needs to be reported just like any other laboratory test. If you do not report a result, you may not always be able to document the workload units or billing. The first thing you need is a well-prepared smear. To evaluate it, you need to look at the feather edge. A well-made smear like this one will have at most 2 to 3 times the number of white blood cells as you see in the body of the smear. If you see more than 4 times as many white blood cells as you see in the body of the smear, you do not have a good smear. Start over. Here's an example. The quality of the stain also is important. In a well-stained smear, the red blood cells are red, platelets are obvious, and the white cells are pretty, the right color. On a poorly stained smear, many things can go wrong. Sometimes red blood cells are green, white blood cells are pathetic, and platelets may disappear.
The quality of the sample can also be judged by a quick review of the smear. An old sample can look like this. Cells degenerate. This can seriously limit the ability to perform a good smear review. But who are you fooling? Would you do a good old-time manual differential on this specimen? And if you see something like this big glob of fibrin, it should tell you that you are not working with a good sample. We know in the real world you sometimes have to deal with these samples. When you see these things on a smear review, you should at least comment on their presence.
Now that you know how to approach the smear, we'll go through what you need to look for when. The art is looking for distributional abnormalities. Remember, you always start a smear review under low power. Sometimes platelet clumps are so large they are not found in the body of the smear, but are found only when shopping at the far feather edge. As you can see here in this slide, the large clump could easily be missed if you were only viewing the body of the smear. Small platelet clumps, as seen on this slide, may not always be seen under low power. Whenever there is a platelet problem, you need to view the smear under low and intermediate power. The presence of any size clump indicates that your platelet count is inaccurate and the numerical result should not be reported. Assess the adequacy and report platelet clumps present. Count appears decreased, normal, or increased. Sometimes, after thorough review, no clumps are found. Remember, instruments aren't perfect, and it could be something else. If you do an estimate and the count is accurate, release the platelet count and report platelet count verified by smear review.
Remember this?
No.
What do you mean, no? The fibrin strands.
Oh.
Whenever you see these, it should instantly make you think platelet problems. If you have fibrin strands, you have platelet clumps somewhere. Go look for them. But even if you do not find them, we recommend you do not release the platelet count.
The science of platelet observations is a verification of the numbers. The point at which you verify either high or low numbers will depend on the accuracy and linearity of your instrumentation. Regardless of your linearity, very low platelet count should always be verified by a smear estimate. Perform an estimate, and if it agrees with the instrument result, release the count and report platelet count verified by smear review. If you cannot verify the count with an estimate, do not release the results and follow your laboratory protocol for discrepancies.
Another instance in which you will need to verify numbers is when you have very small or fragmented red blood cells. Instruments sometimes have trouble separating the two. You will see this either in an abnormal histogram or flagging, which indicates possible interference. This smear shows red blood cell fragments which are the same size as platelets. A platelet estimate needs to be performed to verify the platelet count. If the platelet result is accurate, report platelet count verified by smear review, RBC fragments present. If the estimate does not match the instrument count, do not release the result. Report platelet interference present. Count appears decreased, normal, or increased. RBC fragments present.
There is no science to red blood cell observations. It's impossible to verify abnormal hemoglobin results by smear review. It's just as silly to think we can verify abnormal indices by looking at a slide. Technology today can perform red blood cell measurements better than our eyes can, especially Jerry's. Most often, the art of red blood cell observations includes investigating illogical indice results, such as an MCHC of 49. These crazy results are usually due to red blood cell agglutination, as you see on this slide. Most often, a low-power view can detect the presence of agglutination, and you need go no further. Here is a higher power view of rather marked agglutination. This does not give you the same indication of the severity of the problem as low power does.
Rouleau is another abnormality that can, when severe, affect your red blood cell indices. Rouleau should also be apparent at low power, but remember where you are on the slide when you are looking for Rouleau, because if you go in far enough, you can give anybody Rouleau. This low-power example of Rouleau is the very first field in from the feather edge, where it should start to show up. At intermediate power, you can see the typical 4 or 5 cell stacks, resembling stacks of coin, but not globs. Whether the illogical indices are caused by agglutination or Rouleau, you should not report the results. Follow your laboratory protocol, whether it's heating, washing, or whatever, to obtain valid results. The smear review should be reported as RBC Rouleau formation detected by smear review or RBC agglutination detected by smear review. If you see nothing that accounts for the illogical indices, doing an old-time manual differential is not going to help. You need to investigate the cause, which could be lipemia, severe hemolysis, or something else. Instrument malfunction maybe.
Now we are moving on to the art and science of white blood cell observations. Again, the first view you should have is from far away. On low power, you can detect distributional problems that Jerry already talked about. Another occurrence, which is rare, is white blood cell agglutination, as seen on this slide. Your instrument scattergram or histogram usually has prompted you to look for this abnormality. This is a higher power view. Obviously, your white cell count is suspect, and your differential distribution is off. Unless you can identify and eliminate the cause, there is not much you can do about it. When you see this, you should report white blood cell agglutination detected by smear review. If you do not see it, and the abnormality seen on the scattergram or histogram was due to something else, report white blood cell verified by smear review.
Morphologic flags indicating possible abnormalities of white blood cell types do not necessarily require an old-time manual differential, but should first be approached by a smear review. Verification of these requires examination of 20 to 30 fields using intermediate magnification. For example, if your instrument generated a flag that suggested the lymphocytes might be reactive or abnormal, you would examine 20 to 30 fields on an intermediate power. If you saw cells like these, reactive lymphocytes, you would do a 200-cell old-time manual differential. If after 20 to 30 fields you did not see anything abnormal, you would report no WBC morphologic abnormalities detected by smear review.
What if I saw a blast?
I said any WBC morphologic abnormality, not just lymphocyte. Remember, and this is a big remember, you should also be looking for other morphologic abnormalities besides lymphocytes. Instrument flagging is not perfect. Here's the blast you saw, Pat.
Okay. If I saw even one of these in my 20 to 30 fields, I would do an old-time manual 200-cell differential. Of course, I would also go to a higher magnification to verify it. Here it is.
The same is true if you see an increased number of bands or toxic granulation or immature granulocytes. No matter what flag prompted you to review this smear, you should do an old-time manual 200-cell differential.
Now for the science of white blood cell observations. When verifying abnormal automated differential numbers, remember to use absolute values when setting your criteria. There is one exception to using absolutes: those patients with very low total white blood cell counts. Let's look at how you would verify an abnormal automated diff number. For example, your instrument reported 900 eosinophils. On smear review, you see this, lots of eosinophils. Are you going to do a diff? I wouldn't. I just report white blood cell automated differential verified by smear review.
What if I didn't see any eosinophils?
Then you get to do a 200-cell diff.
Not me. Another part of the science of white blood cell observations is WBC estimates. Remember, at best, they work poorly. And that's the art and science of smear review. What does it accomplish? You can cover far more territory and detect abnormalities you might miss if you are focusing only on the old-time manual differential. Remember window shopping. If done properly, it is almost always faster than a manual diff, and you get more information for your time and money spent. We want to thank you for listening. We hope the information we've given you is helpful. It does take practice to get proficient at smear reviews, but once you practice, you will save a lot of time in your laboratory. Say goodnight, Pat.
Good night, Jerry.
Okay, good night, Pat.